So the treatment of cancer patients is always difficult, but particularly challenging in the era of COVID-19. My institution in Northern California implemented a lot of changes very early, sort of in early to mid-March. California, especially Santa Clara County, where I'm located, was one of the hotbeds early in the United States. But fortunately, because of very strict social distancing that went into effect again in mid-March, we never had the big surges that happened to lots of places in Europe, as well as in the East Coast of the United States. So fortunately, I haven't had to treat patients with COVID, but that doesn't mean that our world hasn't changed in regards to what we do with clinic. So I just had clinic yesterday, and it was like clinic has been since mid-March, meaning that well more than half of my patients are no longer there in person. Their visits are all virtual. The only patients I see in person are ones who are getting an infusional therapy in the same building where my clinic is located, so they're already there. Or occasionally we have patients who really feel that they are not going to be able to do a video telehealth visit, and then I'll see them. But it's only about a quarter of my patients that come in person now. When I show up to clinic, I have to go through one door. We just have one clinic entry now. Everybody is asked questions about symptoms. Everyone is given a mask as soon as they arrive, and we spend the rest of the day wearing masks, unless we are eating, and then we have to make sure that we are a good distance from anybody else at that time. And so the clinic staff has been moved to remote when possible, so that we have very few people in the workrooms. Because most patients are virtual, we have very few patients in the waiting room. So we're really trying to make sure that we do not have crowding at any time, and everyone is masked. We are, of course, washing hands. We always have, but even more so. And when a patient is physically there, we're also wearing gloves. My institution decided not to, in the decision about what was essential and what wasn't, when we weren't sure where we were heading in March and worried we were going to have a surge, of course, many elective surgeries were halted, but we never considered cancer surgery to be elective, so those have continued on. The volumes of new patients have decreased, a lot of it because many of our referrals came from a distance and people have decided they don't want to be driving. They'd rather just stay local. I have had more frequent communications with a lot of the local community oncologists, not local to me, but local to many of the patients. And so I've continued to manage people, but with another step in between with another provider. And have also, for patients who had come to see me who lived a distance away, they're all doing telehealth. So we're trying to get labs for them locally, imaging done locally, and be able to continue to monitor their cancer, make sure that we're making adjustments to treatment as necessary, but not letting go of the principle that the cancer is an immediate threat to their life still. And even though the risk of COVID is always there in this era, we need to continue to treat the cancer the best way we know how. For patients who are living with lung cancer or just diagnosed with lung cancer, and I have had a few who were recently diagnosed during the pandemic, the cancer treatment remains the top priority, and obviously keeping them safe from COVID-19 at the same time. But we haven't made adjustments to what we think is the best cancer care related to the pandemic. There are certainly changes. The family's not there with them when I'm having a visit. Again, most of the visits are done remotely. But in trying to choose what's the best treatment for a given patient, what's happening with COVID doesn't play a role in that. So for a patient with newly diagnosed advanced stage disease, we still need to determine between the options of chemotherapy, immune therapy, and targeted therapy, what's going to be the best option. And the first step of that is doing the molecular testing to figure out if they have EGFR or ALK or ROS. And now with recent approvals for RET treatment with selpercatinib or for MET exon 14 with capmatinib, we need to make sure those are being tested for all patients as well. And when we find one of those targetable mutations, we're going to treat with one of the oral tyrosine kinase inhibitors. Now that is a good thing for a patient in COVID as well, because they're not going to need to be seen as frequently. They're not going to need to come in for infusions. We still need to make sure they're being monitored, especially for patients I'm starting newly on therapy with a tyrosine kinase drug. Most of them are going to need labs within the first couple of weeks. For, depending on the drug, they might need EKGs. And they're still going to need their imaging after a couple of months, but we can do video visits. We can monitor rashes that way. We can do a lot of treatment over the phone without them having to leave their home. And so if a patient is eligible to get a tyrosine kinase inhibitor because of ALK or any of the other drivers, that's great. If they don't, then we need to make the decision between chemotherapy and immune checkpoint inhibitors or combinations of those. So if a patient has high PD-L1, and I can pick single agent pembrolizumab, just like we would normally be selecting that option, that hasn't changed. I have not been avoiding using immune checkpoint inhibitors in the era of COVID. There was one report that came out of Memorial Sloan Kettering suggesting that maybe patients on that class of agent had higher risks from COVID-19, but other analyses, including one I'm a part of called TerraVolt, which is a global registry of lung cancer patients, we did not see that use of immune therapy was a higher risk for poor outcomes in patients who had lung cancer and COVID-19. And other databases have also shown that that was not a higher risk. Obviously, patients who have lung cancer who get COVID-19 are also frequently patients who have other comorbidities, which would make them at risk of higher mortality from the virus. And that has indeed been seen, but it's really not clear that the treatment per se makes the outcomes worse. It's just that patients have an underlying illness and often other comorbidities. And so from that perspective, the goal has been trying to limit exposures to patients. So anytime a patient leaves their home and goes out, whether it's to the grocery store or to a cancer center, they're potentially interacting with other people, and any interaction with another person is a potential for exposure. And so that's what we're really trying to mitigate and reduce. If a patient with lung cancer does end up with the virus, then of course it is more serious for them as it would be for anybody else with underlying comorbidities. But the treatments should not necessarily, we're still trying to focus on treating their cancer. If they have active infection and are ill, then clearly the COVID-19 is the higher priority for that time until they get better, but then the cancer comes back. So I haven't had to change my treatment strategies for any of my patients. And again, we're looking for the tyrosine kinase option if it exists, but if they're not already on it or it's not the right plan, we're not going to switch to that. If they have a choice between chemotherapy or chemotherapy plus immune therapy or immune therapy alone, again, we use all of the rationale for picking between them regardless of what's happening with the era of COVID. For patients who are on immune therapy, we did get authorization or approval in the US to give pembrolizumab now every 6 weeks instead of every 3. And so that is something I'm considering, but you trade off that checking in with patients a little bit more often to having them be seen less often. And so again, that's going to have to be an individual decision.